Thank you so much. It's such an honor and a privilege and a pleasure to be here with you guys today. So I titled my talk Personalized Medicine because I'm a physician scientist where I am performing personalized medicine on a disease that I'm also battling as a patient. This is a picture of me as a healthy third-year medical student at the University of Pennsylvania, where I was training to become an oncologist in memory of my mom who had passed away from cancer a few years before. And this is a picture of me just a few weeks later, where I was dying in the intensive care unit at the University of Pennsylvania with multiple organ system failure. I gained about 70 pounds of fluid due to liver and kidney failure. I had a retinal hemorrhage and went blind in my left eye. And I was so sick that my family brought in a priest to read my last rites to me. So over the course of 6 months, I spent about 4 months hospitalized, most of that time in the intensive care unit. Most of that time without a diagnosis, but eventually a lymph node biopsy was done to try to figure out what it was that was killing me. This is an image from my lymph node, and I'm not going to go into the details, but the one thing I want to highlight is the increased vascularity. There's lots and lots of blood vessels in this lymph node, which would come in to be an important fact later on in my journey. So eventually, based on that lymph node biopsy, a diagnosis was made. Idiopathic multicentric Castleman disease, a rare and deadly disorder where your immune system becomes hyperactivated, attacks and shuts down the body's vital organs for an unknown cause. IMCD is one of a number of subtypes of Castleman disease. Castleman disease is diagnosed in about 5,000 patients each year in the United States. My subtype, idiopathic MCD, within 5 years of diagnosis, 1/3 of patients will die, and then within 10 years of diagnosis, another third of patients will pass away. This is a picture of my dad and I. Right around the time that I finally received my diagnosis, I began treatment with multi-agent chemotherapy. I got adriamycin, Cytoxan, etoposide, Velcade, Dex, thalidomide, rituximab. And that combination of 7 chemotherapies were finally able to turn my disease around. And just to give you a perspective for how sick I felt before, I actually felt better with every single dose of adriamycin, Cytoxan, etoposide, and that full combination of chemotherapy. But I was so sick before that my chemotherapy kicked in and started to work, and I began to improve. My organ failure began to subside. And here I am sitting up for the first time with my dad, and then you can see my dad and I getting ready to go on a walk around the hematology oncology floor. This picture was actually taken on New Year's Eve of 2010, towards the end of this 6-month window in and out of the hospital. My dad and I decided to go for a walk around the hemonc floor on New Year's Eve, and as we passed by the family waiting area, we noticed that there was a gentleman who looked like he'd been drinking on New Year's Eve. He was kind of swaying in his chair, and so on the second lap, we noticed that he had fallen down to the floor, and my dad ran over to him to help him back up into his chair, and he looked at us and he said, "Thanks so much, good luck to you and your wife." And my dad and I rounded the corner like, "Wife, what's he talking about?" And then I looked down at my belly and I realized he thought I was my dad's pregnant wife, which was a low point emotionally for both of us. But I turned to my dad and I said, "Man, you've got an ugly wife." But we laughed pretty hard about that. And that was also the start of a new page for me, where I was beginning to improve and eventually was able to leave the hospital. This is a picture of me just a few weeks later after I was discharged, and you can kind of see how someone maybe could confuse me as a pregnant woman due to the liver and kidney failure and all the fluid that had accumulated. This is actually a picture of me. I played football at Georgetown, just down the road from here. This is a picture of me as a college football player. And I think this is probably the worst before and after picture you could ever have. But if we could flip the order, then we could make it a commercial for like Shake Weight or Muscle Milk. But unfortunately, it's in the wrong order. So I took a picture of myself every week for the next 8 weeks after I got out of the hospital, and you can see my hair starting to grow back, and you can see some of the fluid going away. I look a little bit less like a pregnant woman towards the end. And of course, I took pictures from the side as well, and these are them. And again, you can see the fluid going away and my hair starting to grow back. So after spending this time in and out of the hospital and finally being able to go home, I began to recover back in North Carolina with my family, and I was treated with an experimental drug called siltuximab. Siltuximab targets interleukin-6, and at the time, we believed that interleukin-6 is what drove the hyperactivation of the immune system in idiopathic MCD. And so I was on this drug. It was the first ever randomized controlled trial of a drug in idiopathic MCD, and I was back to medical school, and I was hopeful that this disease would never come back. I was on the drug that was the first drug to be in development for it, and I really was feeling great. So I was able to return back to Penn for medical school and back on my track to become a clinical oncologist to treat patients in memory of my mom. I was really interested in the time in rare disease research. I was on an orphan drug, I had a rare disease, but I wasn't very interested in Castleman disease research, mainly because I knew that other people were on the case. I knew there were some researchers in Japan and France and across the US that were doing some Castleman disease research, but I did end up doing one study within Castleman's, and that was a case report on myself. So I was the first author of the study. I also was the patient described in the case report, and then I was surprised to find a picture of my chest on the cover of their journal. So they also included that photo as well. But the reason I wanted to write this case report about myself is that actually when I first showed up in the hospital, when I was first in the ICU, I spent about 23 hours of the day unconscious, but for about 1 hour of the day I was awake and somewhat with it, and I was totally fixated on these blood moles. So blood moles or cherry hemangiomas are little tiny balls of blood vessels that appear on the skin, and I was totally fixated on it, and I kept asking the residents and the fellows, even the people bringing in food, I would ask, what about these blood moles? And I remember my fellow turned to me and he said, David, your liver, your kidneys, and your bone marrow are failing. Forget about the blood moles. That's the least of your worries. But what I found with subsequent relapses, and I've had a number at this stage, is that leading up to each one of my relapses, these blood moles begin to grow on my skin and they subside with therapy. So I really wanted to get that story out to the community. So I was able to return to Penn Med and spend almost an entire year back in medical school on this experimental drug when I had a full-blown relapse. So the liver failure, the kidney failure, bone marrow failure all occurred, and I was back in what was now my fourth fight against the disease. I oftentimes call it my fourth overtime. I consider when I had my last rites read to me in 2010 to be the start of my overtime, time that I never thought that I would have. So I guess this would make it the start of my fourth overtime. And you can see here I'm actually just getting the start of an infusion with my 7-agent chemotherapy cocktail. And actually they gave me a big dose of dexamethasone beforehand. So that's why I'm like ready for war in this photo. But over the course of the next month in the hospital, I went through a lot of ups and downs again. I nearly died again for the fourth time. But towards the end, and as my 21-day chemotherapy cocktail came to an end, I really was feeling much better. And this is actually the last day of my 21-day cycle. And you can see I have my chemo bag on one shoulder, and I have my now wife, but my girlfriend at the time, on my other shoulder supporting me. So what was really important about number 4 was that as soon as I started getting the chemotherapy that I shared about, my doctor came in the room, and he's the world's expert for Castleman disease. And I said, okay, Dr. Van Ree, we know my immune system goes crazy in IMCD, but what causes this? And he said, no one knows. I said, okay, well, what are the key cell types that are driving IMCD? Well, no one knows. Well, what about the key signaling pathways that are critical? Well, no one knows. And I said, well, I'm on a drug that blocks interleukin-6. I've relapsed on it. Are there other cytokines that we know that could maybe be driving the immune hyperactivation? And he said, no one knows. And then the last question, which was probably the toughest, is, are there any other drugs in development? Are there any other targets in development that could be promising that maybe could be used on me? And he said there weren't. And so when Dr. Van Ree left the room, I turned to my sisters, my dad, and my girlfriend at the time, and I told them, I'm going to dedicate the rest of my life, however long that may be, to trying to cure this disease. This is a picture from a few weeks later, so at this stage my hair had all fallen out from the chemo, but I was on a mission at this stage, and I decided to start out by trying to understand what was being done for Castleman disease, what research was being done, and as I looked at the field, I found that no one was collaborating. I found that the few researchers that were doing any work in Japan, France, and the US were not working together. There was no diagnostic criteria, there was no treatment guidelines, there was very little active research being done, and there certainly was no patient involvement in the little research that was being done. So at that point, I decided I would really take two paths forward. The first is that I would begin conducting laboratory research into idiopathic MCD at the University of Pennsylvania. And secondly, I would start a foundation called the Castleman Disease Collaborative Network to bring together physicians, researchers, and patients from all over the world to take on a unified fight against Castleman disease. And as I began to form the CDCN, I thought a lot about and I learned a lot about the way that rare disease research is often pushed forward. And what I found is that rare disease research foundations typically raise money and then invite researchers to put together RFA, or to respond to RFAs or RFPs with the best ideas that they have for how to advance research for their disease. And that approach works really well when you have a common disease. When you get hundreds or thousands of applications, it's highly likely that one of the applications that comes in is really, truly the most important study that needs to be done, and it truly is going to be done by the most qualified person. But in the rare disease space, where you get 2 or 3 researchers that respond to these RFPs with their ideas, it's extremely unlikely that those 2 or 3 researchers are going to A, have the best research idea for what needs to be done, and also B, be the most qualified people in the world to do those studies. And for that reason, rare disease research is really kind of like hoping that the right researcher applies for the right project at the right time with the right skill set. And when you have a rare disease, you don't want to just hope that all those stars will align. So with the CDCN, we decided to take a really novel and new approach. And that's where, instead of raising money and inviting people to apply to use the funding, we decided that we would build a community of patients, researchers, and physicians so they could work together to prioritize what research should be done. Once we prioritized it, then we went out to recruit the best people in the world to do that research. So in the midst of a lot of progress, we published the first ever diagnostic criteria, the first ever treatment guidelines. That drug, siltuximab, got FDA approved, the first ever FDA approved drug for Castleman disease. We now have over 20 research studies that are actively going on right now, a number that we've already completed. In the midst of all this progress, I was able to complete medical school. You can see the photograph here. But unfortunately, a couple months after medical school, I started a business school also at Penn. And in the midst of my first semester of business school, I had a full-blown relapse. So the liver, kidney, and bone marrow failure all set in. And again, I was back to the intensive care unit and battling for my life for the 5th time. The photo that's on the right of the screen is my wife and I at our engagement party. So around that time, I had proposed to Caitlin, and I had also, right around that time, had my 5th life-threatening flare, and again needed multi-agent chemotherapy. I'd run out of all options. 14 different drugs had been tried on me. Nothing was able to keep my disease in remission. I actually relapsed while I was on 4 chemotherapy drugs for maintenance. And so at this stage, I knew that if I wanted to make it to our wedding day, then I needed to identify a new drug and a new approach to treating Castleman disease. And so just to kind of frame where we were and the task at hand, this is just a cartoon representation of the immune system. These are just 10 of the hundreds of different immune cell types. And so we know that the immune system becomes activated in Castleman disease, but we don't know what the cause is. We don't know which of those immune cells are actually the drivers of the disease. Within each of those cells, we don't know what are the key signaling pathways that are critical to disease. And then we don't know what effector cytokines are being produced that cause the multiple organ failure that we see in Castleman disease. So my task at hand was to identify a new target somewhere within this pathway that could potentially stop and halt my disease. So I was back at the University of Pennsylvania, and I began to just dive into the data that I'd been generating. In the months leading up to my last episode, I'd been running cytokine panels on my blood every month. So I'd been measuring about 13 cytokines leading up to it. And what we found was that during my active disease, all of the cytokines were elevated and really through the roof. But what was really interesting is that there were 2 cytokines that began to rise in the months leading up to that flare. And we thought that could give a sign that maybe those are critical to disease pathogenesis. So one of those cytokines is vascular endothelial growth factor, a growth factor that's critical for blood vessel development. The other one was soluble IL-2 receptor, which is shed by activated T cells. So this has started to give us an idea that maybe T cells are a critical component of this immune response. And certainly, as we thought back about the blood vessel growth, the cherry hemangiomas on my skin, as I shared about the blood vessels as part of my lymph node diagnosis, the VEGF certainly fit within that picture. Now, I'd also stored some serum samples on myself during 2 previous flares, and so I ran a 315 analyte proteomic platform on them, and I was able to confirm that actually soluble IL-2 receptor and VEGF were 2 of the top 5% highest and most upregulated proteins during flare as compared to remission. So we could validate that they're early risers, and during flare, they're 2 of the highest and most upregulated proteins. So we began to think, well, should we be targeting T cells, maybe with anti-thymoglobulin? Should we be targeting VEGF with maybe bevacizumab? Should we try one of these drugs that's never been used before in Castleman disease to treat me? Now, unfortunately, both of those drugs have really significant side effects. And so since we really didn't know, should we target the T cells or target the VEGF, we struggled with what to do and began to wonder, is there something upstream, something that's critical to both T cell activation and VEGF expression that could be a solution, something that we could target? And so we ran another proteomic platform measuring 1,300 serum analytes on those samples, and we put the data through a number of pathway analysis software. The PI3 kinase AKT-mTOR signaling pathway was identified as a potential candidate pathway that's involved in both T cell activation and VEGF expression. Now, there's a really straightforward assay for mTOR activation. So we did immunohistochemistry for phospho-S6. This is first a reactive, so kind of a normal lymph node. Anything positive would stain brown, and you can see that there's very little staining for mTOR activation in this normal lymph node. And then you can see my lymph node that we stained, and you can see just really stark contrast between a normal lymph node and my lymph node, really confirming that the mTOR signaling pathway was turned on and it was hyperactivated. Of course, we didn't know if targeting it would do anything, but we decided that this was our best shot, a drug that could target mTOR, VEGF expression, and T cell activation all in one, and that drug is sirolimus. It's an FDA-approved compound that was developed for kidney transplantation as an immunosuppressant, but has been around and has 25 years of safety data. 62.3 months ago, I started myself on sirolimus, and I've been in my longest remission, about 6 times longer than the previous average remissions that I'd been on. Now, when you have gone through what I've gone through, it's 62.3 months, because you don't round down. I worked hard for those 0.3 months, but you also don't round up, because I recognize that it may not be any longer than 62.3 months, and that I may be back in the hospital at any time. The New York Times ran a story about this, and they said, "Doctor, cure thyself," which I think is a bit of an overstatement, but really excitingly and importantly, in this time during this 62.3-month remission, my wife and I were able to get married several years ago, and then just 7 months ago, we had our first child, Amelia, and I was hoping she could come today, but she's actually taking a nap right now in our hotel room. Amelia has been the greatest gift in the whole world. Importantly, we've also begun to give sirolimus to other Castleman disease patients. So far, we've treated 10 different patients with sirolimus. This is a photo of one of these patients who was hospitalized in the intensive care unit at CHOP right next to Penn. He failed first and second line therapy, and he's had a really brilliant response to sirolimus. This is him with his 2 siblings. And this is another young patient who also struggled through multiple lines of treatment. She failed 4 lines of therapy before she's had a really, really positive response, an extended response on sirolimus. So now we're getting ready to launch a clinical trial. We're going to be giving sirolimus to 24 treatment-refractory idiopathic MCD patients over the next year. And I'm obviously really eager to find out the results of this really important clinical trial. I'm also really excited that I have tried to get together a lot of what's gone over the last few years into a book, which is going to be coming out in September of this year, Chasing My Cure. In Chasing My Cure, I'll be sharing a lot of the themes that hopefully came across today that I just want to highlight in closing. So the first is that life is short. We're all in overtime. We need to make the most of every second. The second's for the gentleman in the room. I hope you're never confused as a pregnant woman But if you are, I hope you'll find humor in that and all of the other challenges in life. The third is to question the status quo. If I hadn't done that, I most certainly wouldn't be on this drug, and I likely wouldn't be here today. The fourth is to think about off-label drug use and the potential. There's 7,000 rare diseases, 95% of which don't have a single FDA-approved therapy. How many drugs are already FDA-approved for one thing that might be life-saving for another? I also want to encourage you to think about and reflect on those things that you hope for and you pray for, and try to do what you can to turn those hopes and prayers into action. And lastly, I hope you'll find your Castleman disease. Find that thing that motivates you and inspires you that you can run after. And if you haven't found that yet, I hope you'll run after Castleman disease with us. We could certainly use your help. Thank you guys so much.